And wow, what a case.
Yeah,
Do you have the
beautiful.
endoscopic image there? These humongous gastric fundic varices. I think there's no question that these are varices, but in case, occasionally the differential arises whether it could be a GIST versus varix. If this patient didn't have a history of liver disease, for example, you could very quickly differentiate the two by just performing instrumental palpation. Of course, it just would be very firm, and this is obviously very soft. And we're going to use that maneuver later on after we treat the varices and fill them with glue. Classification, this is clearly isolated gastric varices type 1 according to the Sarin classification. I don't see any red spots. So no red spots. This patient has not bled in the past, but my understanding is that the varices have gotten larger over a time.
So what's your policy on prophylactic gastric varices
Well,
obliteration?
I'd say ever since the Misha paper came out in the Journal of Hepatology, we're a little bit more encouraged to consider prophylactic treatment. That paper very clearly showed a benefit to prophylactic treatment with cyanoacrylate glue compared to beta blockers compared to no treatment. So I think we need to see more data to validate that paper, but I think that paper certainly gives us some legs to stand on in terms of prophylactic treatment. No esophageal varices here.
So Ken, do you always do an EUS for all your gastric varices?
So the answer is yes in my case. I mean, in our practice, probably about 4 years ago, I switched to doing everything under EUS guidance. But I have to say, that was inspired by some personal experience with complications from glue injection, namely one case of embolization to the lung that was fatal, and then I had another patient with a patent foraminal and the emboli then went to the brain, into the arterial system, and the patient became paralyzed. So after a few complications like that, I started thinking about how can we potentially reduce the risk of embolization. And that's why I started looking at the possibility of deploying a coil first, followed then by glue. All right, you can see here, I'll make this a little bit brighter for you, and obviously if you throw on the Doppler, these are all of these collaterals. Most of these are outside, and I'm going to look for a view here. You can see the lumen here. This is the fundus, okay? So this would be sort of the area of the cardiofundic region here the varices. And when you inject glue, just glue under EUS guidance, it's actually a little frightening because you'll see the glue actually swim away, and you're wondering, gee, I wonder where that's going. And so the coil, these are synthetic fibers that are attached to a platinum body, and these synthetic fibers act as a scaffold to hold the glue at the coil. So the coil is retaining the glue and preventing it from embolizing.
Angiocoils, the standard angiocoils.
Oh yeah, these are standard angiocoils, and these come in two different sizes for a 22 and for a 19 gauge needle. Now these are larger varices, so we want to use a larger coil. So we'll use a 0.035 inch coil, and we've selected one with a 12 millimeter diameter. So you can see that the sheath now has been advanced out. You can see it right there. It's a little echogenicity. All right, now the next step is we're going to look for the needle, and you can see it right up at the top. And we have a little bit of our moving target. So I'm just going to sort of take a look and see what would be the best spot to go for here. So we need to make the needle tip sharp now, so I'll have Gary just pull back a little bit on the stylet. And then this part is just a regular stab in there. Okay, I'm inside. You can see the needle very nicely inside. I'm just going to hold this position. This is where I need Rob to really concentrate and help me by just making sure my scope doesn't move. And the first thing Gary's going to do is aspirate and confirm that he's getting blood flow back. So, and he should. Okay, he got blood. Now he's going to skirt about 2 cc's in there. And you're going to see the swirl of the saline going inside of the varices.
Coil, please.
All right, so now we're going to insert the coil, and so there's an introducer that he's going to insert into the hub of the FNA needle. The coil coming out, so keep pushing. It's very echogenic. You can see it swirling, coiling up inside there. There it is. Nicely. Very nice. So you can see all of this beautifully with EUS. He's pulled out, and we can put another coil in. You can see that here. And now flesh it again with some saline.
You
You
could
can
have
see the
another
saline going
note,
in.
so we're
So
working
now
on
the
watering it.
fibers on the coil are going to retain the glue as we put it in. Now, you're going to see some of that glue swim around there, but the coil is going to prevent
Okay,
it from
so
embolizing.
injecting
At
glue
least that's the
now?
theory. Go ahead. Now they're using histoacryl diluted with lapiodol. He has to flesh out the dead space now. The glue is in the dead space. Now it's
about
going in.
1
It's very
cc,
echogenic.
1.5,
And you'll see how very quickly that whole
2,
area is going to turn
2.5.
basically
that should be
white.
all of it.
Okay.
You can put a little bit more in
Put
if
a
you'd
little
like,
bit more, yeah.
just to make sure we got it all. There we go.
That's very nice.
That should be.
So now at this point, I'm ready to pull the needle back, okay? So I pull the needle all the way back, I lock here, and then what I do is I advance the sheath forward just a little bit, and then I pull the scope out, all right? And once again, you can see no esophageal varices here. And now I'm going into the stomach, okay? And I'll go into retroflexion again, just as before.
Oh,
And here's the appearance. You see how it's just kind of bouncing
great.
off?
beautiful.
Look, it's really hard.
looks good.
It's really hard. So this is now your GIST tumor.